All right, everybody. So I get a ton of questions about essentially SimLab, putting together your care plans, trying to figure out what the heck is going on. And you can also use this if you're starting anesthesia clinical and you're trying to kind of put your care plan and everything together. Because I know it is so freaking confusing, right? I was so confused when I was in y'all's position as well. But before I get into that, I can't say this enough. If you are going to see your care plans as annoying and useless and stupid, then they are going to be annoying, useless, and stupid, right? Use them for your advantage, especially if your program is like it's a requirement. You have to bring them to clinical, whatever it may be. Every program's a little bit different. Use them to your advantage. Okay. And if your preceptor doesn't like your plan, they didn't use your plan, ask why. Notice why. Maybe there was nothing even wrong with your anesthesia plan. Excuse me, it's just not what they do. It's not what the facility or the surgeon likes to do, right? Because there's so many factors at play. So after every single clinical day, take note of what went well, take note of what didn't go well, take note of what happened based off the plan you created and where it went, right? Use your care plans as a working and breathing document to evaluate and to learn with. You can keep them organized in a binder. You can use a note app, whatever, but just, I cannot stress this enough. Use them to your advantage as you are building your anesthesia toolkit over your time in school. And one more thing, y'all should be going to post-op some of your patients, at least 1 to 2 patients a week, right? Go to the floor and your patients are being admitted and post-op them. I learned so much about my anesthetic from post-oping my patients. You can see if they had any awareness. What was the last thing they remembered as far as timing your verset? Did they have any PONV? How did you do your PONV plan, right? Pain. When did they start remembering things and pack you, right? Did they remember the OR? Did they have a sore throat? You can think like you can learn so much from going to see your patients post-op and taking note of that. Okay. Because remember, you are building your anesthesia toolbox. And yes, I know your preceptors are going to be doing their own thing. Ask why, ask questions, look at things from all angles, right? You are here to learn. Okay. And one more thing, if you remember nothing else about this in this video, just know to have a plan. I don't care if it sucks. Have a plan, have a second plan, have a third plan, communicate your plan, tweak your plan, learn from your plan. Okay. Okay. All right. I'll stop doing all that. Now, what I'm going to talk about is I'm going to break down the pieces of your care plan in this video. Okay. It's basically a 3-step process I'm going to walk you through. This video is going to be step 1 and 2, which is information gathering, being a detective. Okay. So step 1 and 2 is gathering all the information, using all your knowledge that you had as a nurse, that you understand about patients, their medical history, their medications. And then we are going to add a layer on top, which is surgery and anesthesia. Okay. But this all starts with your foundational medical nursing knowledge that you have in school. And then we're going to add that extra anesthesia layer on top of it. That's it. Okay. So step 1 is going to be your patient, which is in your pre-op review and your pre-op interview or your pre-op assessment. Okay. So these are some of the pieces that you are going to be looking at and thinking about. And let me just also say, you guys, this is going to get easier with time. Okay. Obviously, the more you're in practice, you know what you need to ask, you can rattle it off. This takes time to build this. So we're building those blocks right now and just allowing this to take time and progress and all that good stuff that comes with this. Okay. Patience, progress over perfection. Okay. So first of all, you're just looking at the patient's age. Now, patient's age is going to tell you, and even like I'm gonna say BMI. So their age, patient's weight, obviously we need the kilograms because that's how we're going to dose a lot of our drugs. But age and BMI, kilograms, kind of those things are drug pharmacodynamics, right? Your pharmacodynamics, your pharmacokinetics, the sicker the patient or the more extremes of age, the older they are, the younger they are, the more they weigh, the less they weigh, like all of that has to do with kind of your drug dosages. Okay. And you also have to think about, positioning and things as well. But big things, age, BMI, thinking about how those drugs are going to work based on where they're at. Okay. Looking at their allergies. Okay. What allergies do they have to certain medications, to maybe narcotics that you're using? What are those allergies, right? Is it just like an adverse effect or do they legit have some anaphylaxis? Okay. So looking at that and then thinking about your anesthesia plan and all the things that are going to happen with this patient. All right. Big things are antibiotic allergies as well, because you will 99% of the time be giving antibiotics prior to surgery. So knowing all of those antibiotics and how they might mix with each other. Sorry, guys, working on a cold here. How they might interact or mix with each other. But a lot of times, you're not working with pharmacy a lot of the times. You have your Pyxis, your patient, and you have you. So you got to know all of those kind of reactions and things that can happen. Okay. Now, medical history. Let their medical diagnoses guide you. Okay. But two of the big things you're going to look at with their medical history: are they well managed? Are their disease processes well managed? Are they controlled? What are the patient's baseline? Okay, those are all what you think about. Is this well controlled? Are they managing this? What is this patient's baseline? How are they coming to you? I like to return people at the very minimum how I found them. Okay. And then let their diagnoses guide you. Okay. Like if they have sleep apnea, okay, do you wear your CPAP? Right. If they have COPD, are they on oxygen? Do they take, inhalers every day? Can they walk up the stairs? Right. What do they look like? If they have CHF, are they coughing? Are they having any trouble breathing? Are they having any chest pain? Do they have to sleep standing up? Like, what do they look like in their daily life? Can they do grocery shopping? Can they clean their house? Right? They have asthma. Have you ever been hospitalized for it or intubated? When's the last time you had an attack? When's the last time you took your medications or been on a steroid pack? Right? They have atrial fibrillation. Are they always in AFib? Are they in sinus rhythm when they last take their medications? Right? Have they ever had a blood clot or anything? Right? So you're just looking at the diagnoses, and then you're asking a few kind of follow-up questions to see, are they managed? Is it well controlled? Are they taking their medications? When's the last time they maybe had an exacerbation of their illness? Okay. Medications, right? You're looking at number one, are these medications going to mix with my anesthetic? Did they take their Norco? Do they have a fentanyl patch on? Are they, on like morphine or anything like that? Blood thinners are big. When's the last time they took their blood thinner? What's the surgery? Is that okay? Is that not okay? Right? It's going to all depend. Thinking about our anesthetics are always going to vasodilate and depress. Okay. So how are their medications going to counteract with that? We usually like them to have their beta blockers in that day, or we can titrate it in, right? Because it's going to have protection for the heart. So looking at the medications they're on, what they do, how are they going to interact with what we are doing, and when was their last dose of them? Okay. Labs. Once again, labs, right? Looking at their labs. What are their electrolytes? What's their H&H? What's their platelet count? And then once again, letting their diagnosis guide you. Have they had a recent echo? If they have any cardiac issues, right? EKG. They're a young menstruating woman. Pregnancy test. What's their blood sugar if they're diabetic? Potassium for dialysis or renal failure patients, right? If they are renal failure on dialysis, when did they last have their dialysis, right? What does their blood pressure normally run? What do they look like? INR for patients on blood thinners as apical. Do they do a bridge? Do they maybe do a Coumadin? They're doing a bridge. I can't even think of the name of the shot, you guys, right now. I'm losing my brain. The shot they give. It'll come back to me. Lovenox. Are they bridging with Lovenox, right? So looking at all of those things. Social life. Do they drink a lot? A little marijuana, a little cocaine, a little heroin, a little meth, anything like that. Smoking, vaping, all those things. Last time they used the drugs, okay? A lot of times, if they are using drugs, drinking, stuff like that, their CYP450 enzymes are going to be like induced and jacked up. So they could potentially be really quick metabolizers of your anesthesia. Are they acutely intoxicated, right? Are they chronic users, right? So all of those things. And then you just kind of want to see kind of their life in general, which will tell you they're going through their medical history. Like we call them METs, right? Can they walk a block without getting shortness of breath or chest pain? Like I said before, are they able to clean the house? Are they able to go grocery shopping? Are they able to shower themselves? Like, what does this patient look like as they're coming to you? And then you always want to ask if there's any acute symptoms. Have you had a cold in the last 6 weeks? Because they could still be of a very irritable, mine would be very irritable right now. They have a very irritable respiratory tract, right? Which could make them more at risk for spasms and stuff. Do they have any chest pain right now? Do they have any shortness of breath, cough, fever, stuff like that? You're looking at them. Do they have anything acute going on right now? I've had patients just randomly be in AFib. They've never been diagnosed with that before. Probably going to cancel and do a workup, right? And then, of course, our anesthesia questions. When's the last time you ate? And do they have any problems in the past, or anyone in their family have issues with anesthesia, right? So this is just step one. You are just looking at your patient, getting a picture of their health as they're coming to you, which is the same thing you guys did for your patients, right? You assess them head to toe. You looked at all those different moving parts. But now we're going to be formulating an anesthesia plan from that information. All right, part two, or step two, is going to be, now we have to look at the surgical stuff. Now that we looked at our patients, we've got our baseline data on our patient, right? Or maybe we found I need some more information. I need some more tests. That happens too, right? So after we've done this part with our patient, now we have to think about the surgical side of things. What is the surgery? Who is the surgeon? They're going to be residents involved, because closing could take a little bit depending on what year residency they're in, right? So who is our surgeon or surgical team? What is the position of the surgery? Okay. What is potentially approximately the length of time that the surgery is going to be? And then what are some worst case scenarios specifically with the surgery? And guys, the surgical stuff will come with time, because you have to get to know the surgeons. You have to get to know the surgeries. That will come with time. I really didn't have a true in-depth look at the surgeries themselves until I kind of got out and towards the end of my training, because it is a lot. Okay. But I'm going to run through just some things to kind of think about, okay, to kind of help you with your care plans. So page, or kind of, and you can even make I think in my clinical guide, I give you guys kind of like a little chart that you can start marking surgical positions and stuff like that. I believe there's like a little helpful chart in there for you. I will link that below in the video. It's a free clinical guide to help you survive clinical in your first couple weeks. But think supine as things like a lot of general surgery, gallbladders, appies. Gallbladders will be a little reverse Trendelenburg. Appies will be a little, T-Burg, because you're thinking of where's the organ? What is the best way for the surgeon to get there? Knee replacements are supine, facelifts, boob jobs, podiatry, right? So thinking of all, those are all going to be supine positioning. Extreme T-Burg, if you're doing robotic hysterectomies, robotic prostates, they're going to be an extreme T-Burg, right? So you have to think about the implications that come with that. Your fluid management, ventilating them, right? Lithotomy position, urology, cystos, gynae procedures, hysteroscopies, hemorrhoids, those can also be prone. Like butt procedures, anything in the butt can also be prone. Spine procedures can be prone. They can also be done supine and anterior, right? So looking as an anterior or posterior spine procedure. Patient sitting procedures, shoulders, sometimes neuro procedures. So you have to kind of know the implications, complications that can be with sitting, lateral procedures, hips. And then sometimes patients are getting, skin things or stuff, and that could be lateral prone, which just depends. Pain cases, pain injections are usually prone depending on where they're going, right? So looking at these things, positioning is going to be like so key in planning your anesthetic. I'm thinking like, okay, am I going to intubate this patient? Is this going to be like, and we're going to talk about that in the next one. We're going to talk about different types of anesthesia. Is this going to be sedation, right? And then remembering, we are giving anesthesia. Anesthesia is vasodilating, right? What could happen if we have a dilated person and now we have them in reverse T, and now all of our volume is going down to their toes, right? What nerves are we worried about? That's why it's important to know the nerves and the positioning of the arms, making sure you're never torquing someone's neck. The brachial plexus is protected, right? So looking at all those things as well. Supine patients, tuck the arms or we'll have them supinated out. I'm trying to think, checking your patient's pre-op too. What's their range of motion? If they're going to be prone up like this, what is their shoulder range of motion, right? What do they look like as baseline? Sometimes with certain cases, I'll have the patients get on the table and kind of position themselves so we can see where they're not going to be comfortable at anymore. Because once we put them to sleep, right, everything relaxes and you don't want to cause somebody harm, right? So all the things you need to think about. The biggest lawsuits in anesthesia are eye injuries, position injuries, neuropathies, and dental issues with intubating and stuff like that. Okay. So these are the two things to really be thinking about first. And then the next video, we're going to talk about choosing your anesthetic.